So this is a quick tour of menopause as it is at the moment in a few minutes. And my disclosures are as follows. Most of the funding that I receive is from what we call competitive grants. So the first thing I'd like to talk about is the long and short of symptoms, and then I'll talk about the long and short of treatment. So our patients are going to present in three different ways. They're going to present because they've got symptoms, which you're familiar with. They've got concerns. So often a woman will come in and say, my mother had terrible osteoporosis, I don't want to be like her. Or incidentally, particularly as gynecologists, a woman will come in for her routine assessment or a pap smear or irregular bleeding, and then you will talk to her about the menopausal symptoms because she won't have actually declared them to you. So how common are symptoms? Well, this is data from a study we did in Australia and published 2 years ago. We recruited 2,000 women from across Australia and through our electoral roll. So these women are representative of the community. And what you can see from this is 75% of postmenopausal women under the age of 55 are experiencing menopausal symptoms, hot flushes, night sweats. And amongst 28%, these are severely bothersome. They're rated by the women as severely bothersome. But I'd also like you to notice that 42% of the women aged 60 to 65 are still having some symptoms, and 6.5% of women aged 60 to 65 had bothersome symptoms. We then went on to look at women aged 65 to 79, and we're able to construct this graph. So this is women aged 40 to 79. And this is looking at any hot flushes and night sweats. Yellow is any hot flushes and night sweats, and red are moderate to severe ones. So the point I'm making is that there's this myth that hot flushes and night sweats only last a short time. But we are still seeing women in their 70s, some of which have very severe symptoms that interfere with their life. So that's the first point I'd like to make. Secondly, is that vasomotor symptoms are problematic. So this is in the same study, and we looked at the relationship between vasomotor symptoms and other issues and well-being. So for example, not knowing whether you can afford to live where you live next month has a severe negative impact on well-being. But the effect of having moderate to severe vasomotor symptoms is nearly as bad as not knowing where you're going to live next month. So it's a pretty severe impact on well-being. The other thing is anxiety and depressive symptoms. So this is pre, peri, young post, and older postmenopausal. Blue is anxiety symptoms, and yellow is depressive symptoms. And I really want to highlight how anxiety symptoms in women are a characteristic of the menopause transition. And a lot of women, they might come to you for other symptoms like irregular bleeding and not understand that these mood changes are menopausal and respond extremely well to estrogen. But women aren't taking estrogen. What we see is that we see a dramatic increase in psychotropic medicine at the time of the menopause. So women are self-medicating or being helped to self-medicate by taking benzodiazepines, SSRIs, and other psychotropics to deal with their anxiety. But that's almost band-aid therapy for the primary problem. And we also looked at work performance. So this is how women self-rated their workability. And what we found that having hot flushes and night sweats was really associated very strongly with a higher likelihood of poor self-rated work performance, so a 2.45 odds ratio. The only thing that was greater was obesity. So that's about what we see in Australia, but is that relevant to your population? And I put to it is. So we've just recently published a systematic review of all the publications of the prevalence of menopausal symptoms in women across Asia. And the colouring is according to the studies with risk of bias, because Because, for example, if you do a convenience sample of women attending a hospital clinic, that's a convenience sample going to have a high risk of bias because the women are more likely to be unwell, versus somewhere that you're randomly recruiting through the population. So green was no risk of bias, pale green, some risk, 2 risk of bias features, and blue, 1, 2, and yellow is 3 risk of bias features, and all the crosshatch are convenience sampling. So this is the prevalence of vasomotor symptoms, and you can see the better quality studies show a high prevalence of vasomotor symptoms across Asia. This is a study done in Malaysia, which I will talk about briefly. But this is our data from Bangladesh. So this is Bangladesh, and this is Australia. This starts at women at age 30, we start at women age 40, so you really have to look at this section versus this section. And the point I want to make is that in Bangladesh, in a nationally representative sample of 1,600 women, that the prevalence of any vasomotor symptoms and moderate to severe vasomotor symptoms was identical to what we saw in Australia. So symptoms are common across countries. This is the data from the study done in Malaysia. Many of you would be very familiar with this. It was a convenience sample, but if you see around the perimenopause, 65% of women basically had vasomotor symptoms. Poor sleep was common. Joint pain doesn't really differentiate the menopause transition. A lot of women have joint pain, and often it's related to daily work. Vaginal dryness, no surprise, increases, and again here you see anxiety increasing in the perimenopause. So menopausal symptoms are common everywhere. It's not a Western disease. They last well into the 8th decade, and some women well into their 80s. And menopausal symptoms are associated with lower well-being, adverse effects on mood, and work performance. Okay? So if we now look at hormone therapy, I'd like to talk about why and how long. Well, why? Women are living longer. If you look at, again, specifically in Asia, there are countries in Asia which in 1970 women were fortunate if they lived to the average age of menopause. Now women are living 15 to 20 years beyond the average age of menopause, so issues like cardiovascular disease, osteoporosis, type 2 diabetes, which are all associated with menopause, are becoming very important. So this graph shows you, this is men in the red, women in the blue. Someone had a sense of humor, I think, color coding that. And this is the increase in life expectancy, or the decline in mortality since 1970. A higher value is a greater decline mortality. So here is women aged 55 to 59 here, and they have nearly a 60% reduction in mortality and increased life expectancy across East Asia and the Pacific. Why are we seeing these changes? Well, this is the change in the rankings of risk factors. So, in fact, high BMI has become 200-fold more important as a risk factor in the last 15 years for disability-adjusted life years. High blood pressure, about a 60% change in its contribution to risk, whereas household air pollution is reduced as a contribution, iron deficiency is being treated. So these are the things that are being reduced, but BMI is a major issue, and it's a major issue for postmenopausal women. Why? Because what happens at menopause, even with no change in BMI, we see increased abdominal fat. If BMI goes up, we see a greater increase in abdominal fat. So this is fat distribution in pre in the dark versus post in the lighter color menopausal women. And look at the dramatic increase in intra-abdominal fat only related to the menopause transition. And we all know intra-abdominal fat is bad. And so when estrogen levels fall, women shift fat from their periphery to their stomach. It's associated with coronary artery disease, type 2 diabetes, specific cancers, and dementia. In fact, a beautiful study published this year showed that women with a BMI of less than 25, so normal, but a waist circumference greater than or equal to 80, with no metabolic abnormalities, have an increased risk of breast cancer that is probably greater than the worst calculated figures for hormone therapy. So these women are not obese. They don't even have, normally we would talk about a BMI of greater than 88, a waist circumference of greater 88 centimeters as being risk, but this is only a change of greater than 80. So central abdominal fat is bad. What else do we see? Fragility fracture. Sorry, I'll go back to that one. So this is non-obese women and obese women. And got to be careful here. As women approach the menopause, we see a dramatic accelerated loss in bone density. It accelerates across the menopause transition. And by the time a woman is past menopause, she's lost about 66% of her bone mineral density. And then as women age, it's about 1 to 2% per year. So this is a major issue of postmenopausal women. So what about hormone replacement therapy? This is the summary of the revised global consensus statement of the International Menopause Society, but it was signed up by a number of societies, including the US Endocrine Society, North American Menopause Society, European Menopause Society, and many more. And it concludes that menopausal hormone therapy, including tibolone and the new TSET combination, is the most effective treatment for symptomatic women at any age. But if initiated before the age of 60 or within 10 years of menopause, the benefits are likely to outweigh the risks. That estrogen alone may decrease the risk of myocardial infarction and all-cause mortality, again, if within 10 years of menopause or under the age of 60. That although there is a small increased risk of venous thromboembolic disease, it's very rare in women around the age of 50 or in the first 10 years after menopause. And the risk of breast cancer attributable to menopause is rare. In fact, it's similar to what we see with sedentary lifestyle, with obesity, as I've shown you, and alcohol intake. How solid's the data? This is the Cochrane review. This is just one slide of the coronary heart disease, death from coronary cardiovascular disease, and all other non-fatal myocardial infarction. So anything to the left of this line says that hormone therapy is protective. So this little diamond here is the summary for women who start hormone therapy before the age, I don't know why that's flipping back, before the age of 60 or within 10 years of menopause. And this shows you that hormone therapy, both estrogen alone or combined, is protective. If initiated beyond 10 years of menopause, after menopause, there is no protective effect, but also no harm. That's the critical thing. It's been drummed into our minds that hormone therapy is bad for the heart. It's not. Early, it's protective. After menopause, after 10 years from menopause, it does no harm. And what about bone loss? Hormone therapy prevents bone loss. It lowers the risk of all fractures, whereas bisphosphonates mostly lower the risk of vertebral fractures. And it remains the only intervention with proven fracture prevention for women who have normal bone density or who are osteopenic. And most women who fracture actually have normal bone density or are osteopenic. Only 1/3 of women who fracture have osteoporosis, have fragility fractures. Okay. It can be initiated in women prior to turning 60, but occasionally afterwards. So hormone therapy should be given to symptomatic women and all women with early menopause. We prefer to initiate it early but occasionally initiated in older women. Estrogen only if a woman's had a hysterectomy. Oral or transdermal therapy is according to risk, and selective progestogens, which I will not talk about to minimize the risk, but to protect the endometrium. And we treat for as long as there is an indication. There is no cutoff date. It is not the lowest therapy for the shortest possible time. It's as long as one needs to treat. This is just to remind you that very low doses can be almost as effective as standard dose. And this is looking at the effects of oral estrogen and transdermal on thrombosis. So oral estrogen, this is no therapy, transdermal and oral estrogen. In normal weight women, there's a small risk of thrombosis. Most studies would say twofold. This study said up to sixfold. If a woman is overweight, the risk with oral estrogen goes up further. And if a woman is obese, that is when we do not use oral estrogen because of the increased risk of thrombosis. Transdermal is no different to non-use. So we developed the practitioner toolkit for managing menopause. You can download it from the Monash University Women's Health website. I'm not going to go through this, but it basically explains how to initiate hormone therapy and how to make a decision. We tend to use non-oral estrogen if there's an increased risk of thrombosis. I believe you don't have patches here, you use gels. And it's a preference if women are on thyroid hormone replacement. Tibolone is available here. It's highly effective. It reduces vasomotor symptoms. It alleviates vaginal atrophy. It prevents bone loss and fracture. And it is not prothrombotic. There's a small increase in risk in ischemic stroke in older women. The new therapy is combining oral estrogen with a selective estrogen receptor modulator. It's called a TSEC. And this alleviates vasomotor symptoms and protects the endometrium. The limitation of this is that in a lot of the patients we see, the dose of 450 micrograms of conjugated equine estrogen is not enough to protect the endometrium. But it does have a role, particularly in women with dense breasts, when you don't want to stimulate breast tissue. So this is, again, the practitioner toolkit, which this can be downloaded for free from the Climacteric Journal website or from the Monash University Women's Health website. And we list every available therapy, every dose, and how to initiate and manage hormone therapy. The International Menopause Society were very concerned that if our patients don't understand what we're telling them, then it's very hard for our patients to be compliant. So you might recognize some characters here: Rod Baber, past president of the International Menopause Society, Anna Fenton, who was one of the journal editors of Climacteric until recently, and myself. And this is a series of 6 YouTube videos your patients can watch. They're only a few minutes each, and we go through what is the menopause, how will menopause affect my body, what is HRT safe, what is complementary therapy, does it work, and sexual function. And then your patient can come back and ask you some more questions, but it saves a lot of time in the clinic. So basically, in conclusion, my key messages are that menopause matters. It matters in the immediate short term. A lot of our patients don't know that their joint pain could be menopausal. They don't know that their anxiety could be menopausal. And therefore, we need to ask them about these symptoms. It matters in the long term because of increased risks of cardiovascular disease, type 2 diabetes, osteoporosis, weight gain, and all the consequences. And it matters because our populations are aging, and aging dramatically. And this, in your population, is like the postmenopausal woman. She is going from an apple to a pear. And I think you need to be encouraging your primary care physicians and your colleagues to be taking notice of menopause. In final conclusion, the International Menopause Society has opened up opportunities for young doctors and trainees to become members at a really discounted rate and get all the benefits of the International Menopause Society. So please tell your trainees and junior fellows about this. And on behalf of the Society, I look forward to welcoming you in Vancouver in 2018 for the Our World Congress. So thank you.